Welcome, everyone. Let's give people a few minutes to settle in before we get the panel started. Okay, great. I think everybody's had a chance to come in from the waiting room. Good morning, good afternoon, everyone. Thank you all for joining on behalf of the Bayer Foundation and Innovations in Healthcare. I'd like to welcome you to our first webinar in our Inclusive Healthcare series, Preparing for Impact, the Potential of Community Health Workers through Digital Enablement. One second. Oops. My name's Judd Staples. I'm the Assistant Director of Partnerships for Innovations in Healthcare. And I have the distinct honor today of facilitating a discussion with an esteemed group of experts actively working on enabling greater healthcare access at the last mile, working with community health workers and enabling digital technologies. With us today is Ed Booty, with the CEO of Reach 52, joining us from Singapore. Dr. Aparna Hegde, out of Delhi, but joining us today from Miami. Dr. Krishna Jaffa, CEO of Medic, joining us from Seattle. And Dr. Barbara Balloon Maravello, joining us from Madagascar. So we have a truly global panel, and so we're thrilled to have all of you joining us today. I'll be asking a series of questions to our panelists, such as, what is the current status of digital tools implementation with community health workers? Do you see the capacity of community health workers to impact public health changing dramatically in the next several years? Why or why not? What can we do to prepare? Hopefully, this will spur discussions and debate, and I hope all of you in the audience will jump in with questions and experiences of your own. So before I jump in and give the panel an opportunity to introduce themselves and their organizations, I thought I'd take a moment to frame our discussion a little bit. There are opportunities for for digital innovation intervention across the healthcare continuum. There are tools for clients and healthcare providers, health system managers, data, and for data services. Today, we are focusing on what WHO designates as the 2.0 section for healthcare providers, and particularly for those working in the last mile, the community health workers. Of the many opportunities for intervention with providers, we've started to see progress in a few areas. For example, registration and records, these have faced some challenges, and we've seen evidence of impact in activity planning. Where can we expect additional implementation? Let's turn to our panel to find out. Ed, can you introduce yourself, tell us a little bit about your organization and how you currently support community health workers?
Well, hello, thanks, Judd, and good afternoon, good morning, good evening, wherever you are in the world, everyone. And yeah, obviously nice to be with the other panelists here today. So yeah, as mentioned, I'm Ed, set up an organization called Reach 52 based out of Singapore, although now we operate across 7 countries in Southeast Asia and Sub-Saharan Africa. Take our name from the fact that 52% of the world, or 3.7 billion people, can't access essential healthcare. So we want to reach the 52%. Of the world. We see ourselves as a tech company that focuses on access to health in rural areas, training up health workers, and onboarding small stores and pharmacies to our platform. Through that, we can collect data on healthcare needs, run really targeted public health campaigns with a range of different public and private donors, and also look to enable access to affordable products through the network of stores and pharmacies. So yeah, mixture of sort of public sector resources and integrated private sector. We say our mission is to unlock private capital and the power of communities to achieve health for all. So yeah, we're really trying to empower CHWs and pharmacies through tech and sort of use that to unlock more capital through having better data on needs and such to really try and help healthcare reach the last mile. I'll pause there. Thank you.
Thanks, Ed. Aparna, can you introduce yourself and your organization?
Yes, thank you so much, Jad, for having me here. I'm Dr. Aparna Hegde. I am the founder of the NGO called ARMMAN that leverages technology, that is mobile health technology, to create cost-effective, scalable solutions to, on the one hand, inform women about the care to be taken during pregnancy and infancy. So we have voice calling services and going on to WhatsApp and multimedia sources, hand-holding pregnant women and mothers with children till the age of 1 of the child. So they demand care. On the other hand, we train health workers at every level of the health system. So we have the frontline health volunteers called the ASHAs in every village of the country. And then you have the nurses, the medical office and specialists. So we train health workers at every level of the health cadre to be able to kind of pick up the risk factors in time so that overall there is closure of loop of care and there's reduction in high risk, delayed complicated referrals to tertiary hospitals, leading to reduction in maternal child mortality and morbidity. That's our theory of change, and that's what ARMMAN does. And we're working currently in 20 states of India with the government of India. Our programs are all in collaboration with the government of India and state governments. And we've reached 35 million women and the children with information services in 20 states. And we've trained over 300,000 health workers in 18 states of India towards our goal.
Great. Krishna, can you tell us a little bit about Medic and what you do there?
Thank you, Jad. Good morning, good afternoon, good evening, everyone. My name is Krishna Jaffa. I'm the CEO of Medic. We seek to provide equitable, high quality, and just healthcare to everyone, everywhere. And very similar to Reach 52, we focus very heavily on supporting the hardest to reach communities globally. So we go typically where there is no facility, where there are no professionalized healthcare providers today. And we are the technical steward of the Community Health Toolkit, which is an open source digital health tool that enables frontline health workers, including community health workers, to reach individuals where they are. A key part of how we approach our work, and really this is cross-cutting across everything we do, is we apply human-centered design to provide healthcare, and we design all of our digital applications that are open source with and for the communities that we seek to serve. So the community health workers' voice and context comes through in every workflow that we have. We currently provide about 23 different workflows that address various aspects of universal health coverage. And we directly accompany governments in Kenya, Uganda, Mali, Nepal, and we're just getting started after a pilot in Niger. We also work with a number of our partners in varying models that we have. For example, our partner D3 is basically the technical and implementation lead accompanying the Ministry of Health in Zanzibar, Tanzania. And they run pretty much solo. In some other countries, we provide tailored ongoing support to our implementing partners, largely NGOs and faith-based organizations, to deliver healthcare. We currently reach about over 40,000 CHWs globally. Our tool is being used in about 15 countries, and we're really excited to be joining this conversation. Thank you.
Thank you, Krishna. And Barbara, please tell us a little bit about Pivot and what it is that you do.
Yes, thank you. My name is Barbara, and I'm the Director of Engagement at the medical NGO Pivot, which is the medical NGO located in Madagascar. We are currently operating in a rural district in Madagascar, and we are soon expanding. We will be soon expanding in a whole region. And so we have a threefold mission. One is to save lives. So we do provide care at all the levels of care. Number two, we transform the health system, which means that we do health system strengthening. We also sit as technical partners to the Ministry of Health by informing public health policies. And the overall goal is that what we do does not stay in a single district, but it's going to drive population level impact. Number three, we catalyze global change. And one thing that we can pride ourselves of doing is that we are generating a model of health equity, meaning that we are striving to build an evidence-based, replicable model of universal health coverage in a resource-poor setting, which means that we are striving to demonstrate how quality healthcare for all can be achieved by addressing the really various barriers of healthcare. And so because we are more working holistically and in a more comprehensive way, I would talk a little bit about our current community health digitization, which is underway. So we are currently supporting the deployment of the new national community health strategy, which includes key components of our community health pilot projects. And one of these components is the use of mobile technology by community health workers. The app is called ComCare, and I guess a lot of us are already familiar with this since it's used by more than 80 countries in the world and more than 3,000 projects worldwide. So it supports community health worker in family planning, maternal health care, and integrated management of childhood diseases, which anyways make up our target population. And one thing that is worth noting maybe before closing is that we are the only financial partners to the Ministry of Health, which were able to kind of really deploy ComCare or mobile technology to the last mile. And I'll be happy to talk more about this during this panel. Thank you.
Great, thanks so much, Barbara, and thank you all again for joining. So I'd like to start off sort of maybe our round robin panel discussion questions. I'm going to put a question out, and please jump in and answer your experiences from your organization, and then we will have an opportunity for guests on the line to answer to pose questions as well at the end. But please feel free to contribute in chat as well if you have some observations or other experiences of your own that to contribute to the conversation. So first question for the panel is, what challenges have you faced in rolling out digital solutions in the past? Have you considered rolling out a digital technology that is technically ready for deployment, but deferred because another part of the ecosystem couldn't support it? Do you anticipate these challenges persisting? So Ed, I'll put that to you first, but please anybody else jump in.
Yeah, sure. Well, I'm more than happy to go first. And it's, well, firstly, certainly it's challenging. I think, yeah, rolling out digital in rural areas with low internet and old phones. And, you know, I think we've trained about 14,500 health workers, so comparatively small compared to some of the great organizations on the panel. But for most of our health workers, they've never used a tech platform before in their life, right? So, you know, yeah, old phones, bad internet, first time using a phone and or an app for your day-to-day job. So clearly it's hard, and I'm sure there's going to be variations of that complexity from all other panelists. I think for me, I mean, I'm actually going to avoid this sort of, to some extent, CHW techs. I think, to be honest, the other panelists can cover it better than I. But for us, what we're doing a lot of is health workers collect data through an app, and then we try and use that data to drive our programming, right, or drive our campaigns. So we collect, a health worker collects the health and well-being data on their community, and then based on that insight, we look to work with funders to retarget, for lack of a better phrase, specific households with specific health interventions, right? And when I started Read 52, we're 5 years old, comparatively young. I was talking about AI and fancy predictive modeling and, demand forecasting and all this kind of stuff, right? But firstly, often basic dashboards do not exist. It's often locked up on paper. It's very, very basic insights that we don't have, and very quickly stopped talking about AI and so on and started talking about basic graphs and charts and dashboards, because that's a huge leap forward. And linking to our current kind of focus of data-driven models, I'd say pretty much every consumer above the health workers to some extent is not able to consume digital services in some way, shape or form, right? And that's a big generalization. I'm obviously saying it broadly. But if we think about vertical programs, they are funding downwards and it's not necessarily looking holistically at community needs. And I guess my sort of thought experiment when thinking about that question was, if we just had a dashboard on the health needs of all the communities for the organizations on this panel, would people with funding or resources or products be able to consume that and be able to drive their sort of programs or funding, decisions via that? And the answer is probably no. So yeah, for me, basic data is difficult. Setting up basic data collection is quite difficult. I'll cover that separately with other panelists, I think, better. But for me, yeah, the wider ecosystem also isn't necessarily able to consume the data that we could all get to sort of drive programming as well. And I certainly think a lot of maturity needs to happen in the sector there, from my point of view.
Yeah.
Yes, please jump in.
Yeah.
Go ahead, Aparna.
Yeah. So I'll give an India-specific overview of what we've really seen on the field, right? So obviously literacy is a huge issue, digital literacy, right? Especially when you consider the age of the health workers. There are certain cadres which are older, right? And they find it very difficult. They've never used a phone to come in and actually do data collection and implement in the field. Second is mobile connectivity, right? In countries like ours, the most underserved parts of the country where you really need help do not have mobile connectivity. So offline work and then, online integration can pose a problem. Second thing is that supply chain, right? So not even think of a country like India, it's so huge. The number of, you're talking about literally 1 million health workers and access to phones, right? Access to smartphones and also the supply chain. So there are certain states that have given phones to the, all the health workers, other states have not. There's many states they're supposed to download the app onto their own phone. And even if they do that, even if you supply a phone, the supply chain is an issue, right? When they conk off, how do you repair them, right? And how do you kind of keep, monitor, the entire supply chain issues, right? Second thing is that, in our country, no matter how many apps have come in, right? Unfortunately, there's a duplication of work still because paper forms have not gone away. So it's almost as if they have to fill in into the app, and they also have to fill in the paper forms. And then there are too many pilots, right? So there are too many different competing apps. Everybody wants to take an app to the, health workers. So, there's a lot of fatigue now, right? One very important point also I want to make is this, right? The ecosystem needs to improve. An app is not a solution for everything if the basic infrastructure doesn't exist. Right? I'll give an example, right? I mean, we tried to do a program in a small tribal part of the country where we thought that, we would create an app which would take the health workers, the nurses, through high-risk pregnancy management, guide them, right? Guide them through the signs, the symptoms, the diagnostics, and help them come to a diagnosis and management. It seems great on paper, but when we implemented the program, what we realized was twofold, right? Firstly, half of them do not even know how to measure blood pressure, right? So if you do not even know how to measure blood pressure, how is the app going to help you? Second thing is, app does not take care of the, sometimes there is, fudging of data, right? So it's very difficult to ensure that the data actually collected is accurate, right? Especially when you come to hemoglobin and anemia, right? And there's a tendency of just, guessing the hemoglobin, right? And that an app does not really, we don't really have solutions for ensuring verification, right? Third thing is that you've reached a diagnosis, then what, right? What we realize is nationally and in many countries, the guidelines only exist for diagnosis. And after that is a free for all, because overall though diagnostics, management protocols do exist for management of high-risk pregnancy, different high-risk factors. They're not been broken down to each level of the cadre, right? The nurses, the medical officers, and specialists. So they really don't know what to do. So the app just enters diagnosis and then referral. And it really doesn't help improve services. One other thing I want to talk about is the fact that most apps are just data collection tools. They're not, and the data is never analyzed for data-driven action at any level, right? Neither the higher up district officials or taluka level officials or state level officials use the data to actually drive data-driven action, nor is the data analyzed sent back to the health workers in the field. So the importance of the data is not obvious to them. So the motivation to collect data is not there, right? And even if the data is analyzed, and I'll give a small example, right? I mean, you have, we worked with apps which pick up risk factors, and there's an alert system, right? So the high risk factor is picked up. There's an alert system with the primary health center. Unfortunately, once it goes to the primary health center, if there's no data sent back to them about what happened to the woman, right, for whom the alert was raised, or the child for whom the alert was raised, it is the motivation dies off, right? They don't know what was the action taken. So even at higher levels, the action is offline. Mm-hmm. So this true data-driven action does not happen. So ultimately what happens is the data gets used as a 6-monthly reporting tool. I mean, at every level, they're supposed to report data in. So it becomes a data collection tool, 6-monthly reports go off, but there is no analysis and data-driven action, So these are the points I wanted to make. Yeah.
Great, thank you.
Chad, would it be okay to jump in?
Yes, please.
Thank you. I'm just building on what my colleagues, fellow panelists have already shared. I think a few things that really jump out for us are, if you look at what a community health worker is enabled to do, what policies are in place, you often find that the scopes of practice themselves might be quite limiting. Not a technical problem, but definitely sort of, when you're talking about universal health coverage, how can they be enabled to provide a comprehensive suite of services for things that have been proven to be safe, effective, and feasible in terms of community-based care. So, for example, certain diagnostics, there's a lot of difference from country to country about what types of point of care diagnostics a community health worker might be able to use. And as we sort of, move toward a conversation about professionalization, I think also realizing that most of these community health workers, 70% of whom are women, are largely volunteer workforces. They earn modest stipends that really aren't enough to survive on. And as I think one of the co-executive directors of Africa Frontline First said, they are in fact our largest anonymous donor. They do a lot of work for free or for close to free. So payment of community health workers is really, really critical and important. One of the technical barriers there is interoperability and integration with digital payment platforms. That is beginning to happen. And I'm really excited about that, but we want to see a little bit more. Then when we talk about professionalization, we are dealing with moral hazard, where we have extracted close to free or free services from women, sometimes for decades. What do we do? How can we think about reskilling them and not just sort of casting them aside when they've been serving their communities and have built up trust over decades? Then pivoting a little bit more to the technical side of it, I think, as we accompany 5 ministries of health to go to scale, we're really finding that in enabling continuum of care, there are some barriers. We are an offline first technical solution, but we do find that because interoperability is more talked about than actually sort of a reality in many countries, because most countries are still 2 versions behind on the international classification of diseases. So how do you then sort of, establish the use of FHIR standards when folks are already sort of, 2 iterations behind? We're really finding that while there are mediators that we can use on the technical side to be able to help health information systems talk to each other, we find that there are actually quite a few barriers, and it's a pretty heavy lift. And then last, I'll just circle back to, if we're talking about universal health coverage, a digital tool can only do so much if we don't link to all of the level of service functions such as supply chain, such as labs, such as pharmacy, electronic medical records, so on and so forth. We provide kind of one-dimensional care. And so it's really important as we think about building out these community health tools that we take a view of the entire community health ecosystem, and wherever possible, we link to them. And then I'll end by highlighting that self-care is a reality. It's a growing reality. And I think alongside community health workers, empowering them, it behooves our community to also be thinking about consumer, individual, household level empowerment and correcting for the many asymmetries in medical information and self-care that currently exist today, which are possible even with feature phones sending a lot of that information. Thank you.
Thanks, Krishna. Barbara, I know a lot's been covered so far. Anything to add on to that?
Yes, of course. I'm going to echo back a few points that my colleagues here have been raising so far, but maybe looking at them at a more different angle and from the perspective and the context of Madagascar. So, of course, we have also known the challenge of connectivity, which is internet connection in locked zones. And this is really problematic since this constitutes most of the regions and most of the districts in Madagascar. This has, of course, brought the challenges of equity as well, because a lot of the technical and financial partners to the Ministry of Health only work and implement where there is a chance of building internet connection. So I would say that addressing the challenge, and maybe one lessons learned for us, is to really work through a multi-sectoral partnership, which we did by leveraging the Ministry of Telecommunications and operators expertise here. So we have built internet relay points on really chosen locations so that the community health workers can work online first and then walk a while until they reach these relay internet connection points, and can then upload and synchronize their data. So that's one thing. Still, and even though since the general network is problematic in Madagascar, therefore we would still have delayed data synchronization, and we would not be able to really say that we are providing real-time data reporting, although it has really been improved as opposed to when we only worked in paper format. So I would say that here it's really important to identify reliable network points. It would anyways avoid community health workers to take a long walk before maybe finding a suitable internet connection. A second element of the ecosystem, as we're talking about ecosystem, I would say the next level of care, which means the referral center. After community health, we have the primary health centers, and we have known a primary health care center counter reference issues. The thing is that while we gave so much credit and so much importance and really took care of community health and equipping community health workers, the primary healthcare centers themselves did not yet have an effective integration of mobile technology for their work. And we believe, and this is our next step, to really consider the primary healthcare as well for patient care continuity. I would also say, talking about multi-sectoral partnership, that we need, and we would have needed, an energy partner, should it be nationally or internationally. This seems so obvious and so basic, but the problem is still there. So a lot of our community health workers reported problems of charging the phones. And if this does not work out, mobile technology cannot work out then. We granted them accessories, of course, but they reported low charge because the charging time was not enough where we are operating, and in quite a number of districts in Madagascar. We face rainy weather, during all year long, I would say. And because we're using solar kits to charge electronic devices, we have not yet found out like good energy options, which would be affordable, sustainable for the Ministry of Health as well, lasting and with maintenance options. Finally, I would say that in terms of professionalizing community health workers as well, what used to be the norm is that community health workers are people elected by the villagers, by the community that they serve. But now with the new implementation guide and of course, supported by evidence, we would start hiring community health workers, people who, for instance, would be literate or would be able to use the mobile phone. The issue is the community health workers we are working with so far and who are elected by people so far are mostly elderly people, respected people, and there is this ocular health, like vision issues, as they want to use the mobile phone. And so there is for us here a continuous reflection and questioning about there is a moral, like an ethical issue of selecting maybe younger community health workers, which we're going to hire, but which might not be acceptable to the population, but helpful with the mobile technology. We have not tested that yet, and we are weighing patient benefits, acceptability, and health system benefits through mobile phone. I would maybe stop there, Chad. Thank you.
Thank you, Barbara, and thank you all for all that great insights into the challenges of implementing digital tools at the level of community health workers. Obviously, it's not as simple as releasing version 2.0 and watching the benefits roll in. You guys talked about infrastructure challenges with connectivity and charging and supply chain. We talked about professionalization and workforce training around both technical skills with devices, but also medical and clinical skills and data processing. On top of that, interoperability continues to be a challenge, and then just integrating these solutions into community with a community perspective, but also with a perspective of all the other duties and responsibilities and data flows currently ongoing. It's certainly a non-trivial task. So I appreciate all your insights onto that. Maybe moving on to a next question for our panel. What are some successful examples of digital enablement of community health workers and organizations, and how have these improved lives in the communities that you serve? And maybe I'll switch it up. Krishna, do you want to go first?
Sure, thank you. And I think, starting with challenges, it was an interesting sort of a switcheroo, because I come at dealing with these issues with unfettered optimism, and everywhere I look, everywhere that medic works, I think we're really delighted to see the pace at which frontline health workers are able to adapt to digital tools. So that digital literacy, while it is definitely an issue, it's fairly readily overcome. Most folks now today have access to at least a feature phone. Smartphone penetration is going up a lot, so the usability is there. I think some of the most exciting examples that I can share are a recent trip last year to Nepal. I was in Sindhupal Chowk district, which was quite badly hit in the earthquake of 2015, and also has really bad flooding and landslides and things like that. It's about a 3-hour drive outside of Kathmandu. And I was asking the community health workers, what does this do? And they said, it really helps organize my day. It helps me figure out how to schedule my tasks, plan my tasks, communicate with my supervisor to be able to ask for support when needed. if a woman has a high-risk pregnancy, I need to flag that she needs support to be transported to the closest facility for facility-based care. That's possible. And so then I asked, what does that translate into? I assumed that there would still be quite a few at-home births, given this is rural Nepal. And they started laughing, and they said, actually, we've gone since we started using the app, and we can deliver very focused attention to our pregnant community members. We've been able to reduce at-home births to 0. So that's the kind of impact you can see. Now, one of the challenges is that this doesn't necessarily get properly quantified and flowing into health information systems, right? So related to it, one thing that we're working very hard on is DHIS2 integration and interoperability. And we see that as in Uganda, where we've recently sort of set up the interoperability layer between the Community Health Toolkit and DHIS2. The Ministry of Health is really excited to see sort of these inflows of data. So I think we will get to a point where we can objectively verify the value that is provided through these tools. I think sort of overall, another really important success is democratization of access to health information to these hard to serve communities. Absolutely agree with Barbara. We need a cool, low cost, highly effective solar energy partner across all of our organizations. And if we could find one, there's anyone listening, that would be great. And then one more thing that I'm really excited about is actually a partnership with the Bio Foundation and PATH. And it's too early to tell if it is a success, but we think it's very exciting. It's basically a social entrepreneurship model that we've started with in-country technical organizations that we link to sort of build their capacity to serve as technical partners to governments and local implementers for the Community Health Toolkit. And what we love about this is it's central to our theory of change as Medic, which is really building for sustainability from the outset. So being able to empower others to deliver and support the Community Health Toolkit, so we can then step back and focus on maintaining the core system behind the Community Health Toolkit and continue to innovate and potentially start engaging in additional geographies is really exciting. So at this point in time, we've got 4 entrepreneurs who are part of our first sort of class, if you will, and we're really excited to see where they go. They're in Kenya and Uganda, and we hope that, you know, in the next time we have this kind of conversation in a year or so, we'll be able to share some really cool success stories. We also have 8 technical partners with whom we work very closely across Africa and Nepal. And they've continued to really step in and provide high quality support to ministries of health as well for a lot of things. So again, the more we can do to build local organizations, to build in-country capabilities and know when to step back, I think that can be a key metric of sustainability and country-owned successes in community health information systems. Thank you.
Please jump in if you have something to add.
Yeah.
Yes, I think.
Oh, yeah.
Okay.
Go ahead, Barbara.
Yes, thanks, Judd and Aparna. I would say that since Pivot has mostly been working on the application ComCare mobile technology, which was more of the health system strengthening, which has more of the health system strengthening targets so far, I would say that it has supported the implementation of, I would say, really high impact practices. The issue as we started our work was that 1 in 7 children were dying from preventable diseases in locked villages once again. And then for pregnant women, there was a high risk for a woman to die during her pregnancy, childbirth, and postpartum journey. So there was too little and too late made for her, despite really easy management, sensitization, or accompaniment that today these community health workers are doing. And so I would say that the mobile technology has allowed for, first, in terms of health system strengthening, the provision of better data. And first, it did allow for timely decision-making and planning, not only at local level, but also at national level. Of course, now we have precise data that match the national indicators. That has been and is still an issue for the Ministry of Health in Madagascar. Each partner in health just has its own metrics and its own key performance indicators, but with that mobile technology, which has been endorsed, approved, and encouraged by the Ministry of Health, we are sure to match national indicators and relevant indicators. There is a reduction of the delayed reporting, which means that what community health workers report is now complete and timely. I would say that generally where we don't deploy this mobile technology yet, we would have 45% timeliness of data reporting, whereas now we have reached 95% where we are deploying ComCare. It also allows, of course, for a more fluid communication between primary healthcare centers, the higher level of care, and the community health workers. And it can somehow be felt through the services, through the consumables reporting, through the health information system and logistics management information system. For the community health workers themselves, as humans, as professionals, I would say that they have reported easier data entry, faster data entry, and reporting communication, of course, which pretty much reduces the issue of physical distance challenges, because these community health workers used to bring the paper format to the higher level for them to check this out and for them to supervise them. And so it also reduces the usual longer reporting time. I would say from the point of view of the community health workers, really energy saving and time saving, allowing them to devote more time for patient management, sensitization, or proactive care, whatever. We have seen an improved skills of those community health workers. Mobile technology does not go alone. It goes on with training, continuous learning, especially through regular supervision. I would give a very specific example for child diarrhea, for instance, which is a major cause of death. There is a slight difference between the management of bloody diarrhea and just water diarrhea. And this is just one small detail that we've seen most of the community health workers tended to omit, but then thanks to ComCare, which helps them to adhere to the right protocol, which help them to walk to the right management algorithm. I mean, there is an improved adherence to disease management now, and improved quality, absolute quality of service, and community health workers as users satisfaction. I would
Barbara, I want to be sort of mindful of time. So thank you for sharing. I want to get to the sort of future looking questions, and I know that Aparna had wanted to note some success on her.
Yeah.
Thank you.
So I won't add to what Krishna and Barbara have already spoken. So we've also got instances where direct, electronic new app usage for, better management of patients has worked. I'll go on to how we use the app for learning, right? So we do this whole program called Mobile Academy, which trains ASHA workers, frontline health volunteers in 17 states of India. And we are actually going on to multimedia, content. And so learning, and it's same thing for the nurses, medical officer specialist, right? So we've actually creating content, which multimedia and associated with two-way communication, long-term hand-holding, right? Because training happens face-to-face, and when it's face-to-face, it's just one-off, right? You need to support that with long-term refresher training and hand-holding, and then two-way communication, and apps really allow that to happen. So we're doing, I give an example of how when we did this app for nurses, where, we wanted to handhold them in high-risk pregnancy management, we found that, there were a lot of issues. So we actually have incorporated that within a larger program, a larger ecosystem improvement. So we have a whole 5-year program happening with the state of India called Telangana, where we've not only created protocols for high-risk pregnancy management for every level of the cadre, algorithmic color-coded protocols. The nurses, medical officers, especially getting trained in those protocols through the state. So 9,000 nurses, 1,500 medical officers, and 350 specialists are getting trained. And then we're using, after training, we've got a learning app, which has got all of the multimedia content, two-way communication, notifications, simulations, interactive quizzes, which will support the face-to-face training. We also matching that with tracking. So, we'll track pregnant women with high-risk factors end to end using the app system, so that we'll be able to know where to go and do refresher training. So, so we are using the app within the ecosystem, and that's, we're hoping will work much better than just usually using the app for like an electronic record, system. Just to add a few things.
Thank you, Aparna. So, I mean, I obviously, we may have painted a very pessimistic picture coming out of the first question, saying that there are challenges, but there definitely are bright spots out there of really successful programs that have been implemented. Mentioning the timely data collection, upskilling of workers in the field, better diagnoses, and better increased care, lower at-home births or elimination of at-home births, and democratization of health information, and sort of empowering countries to be sustainable in their digital deployment. So a lot of great work. We could spend another hour talking about it, but I want to sort of maybe move on to the final questions, and maybe try and get, if we have time, get questions from the audience. So the last question for the panel is sort of, what do you see over the short horizon, sort of 1 to 3 years, in additional capabilities for community health workers enabled by digital tools? In particular, do you see technologies such as AI making an impact? What would you recommend to other organizations to prepare for tools coming down the road?
I'll maybe jump in, Judd, and try to really be quick. I think that in 1 to 3 years, there is, of course, a growing number of tasks and disease management and administrative tasks as well, which community health workers would have to take over, would have to take care of. I mean, for instance, currently in Madagascar, we are planning to also include other curriculum and other tasks for community health workers. If it was only maternal and child health before, it's going to also include malnutrition and TB patient follow-up, and really integrate that into mobile technology. So in view of this, maybe the questions are, and the recommendations would be, first, how to make these community health workers participate really in the process of developing curriculums, really in the process of deciding whether that is the venue that is to take or not, and how can we be accountable to their preferences and to the challenges that they feel, and the digital solution that they feel are appropriate for them. Second thing, and also related to that, is sustainability. Have we really considered, and should we not consider, the realistic options for sustainable financing? It is the case in Madagascar. We know that the Ministry of Health has really one of the lowest budget and investments in healthcare. And so should we maybe consider somewhere some, I would say, cheaper alternatives, such as SMS or voice calls versus an application, maybe? And in terms of system management as well, has the government acquired the system, and is the government currently in charge of the digitization management and its monitoring and evaluation? I think these are questions worth thinking about. There is one more thing, it's about interoperability. So once community health workers will endorse a lot more activities, family planning, injectables, for instance, and so forth. How do we ensure that everything that is entered in the app is interoperable with the higher levels of care? And I think that is something which is a huge debate, but worth considering as we are talking about this. And yeah, so finally, I will talk about the ethical issues in the context of a resource-poor setting in underdeveloped countries like low-income country like Madagascar. Can we first guarantee data security? And this issue has been flagged as a major issue in November 2022 workshop about digitization by the Ministry of Public Health. So that would be one big bullet point worth partnering for and worth reflecting about. Towards more advanced clinical digital health tools in general, how about patient centricity? I mean, where is the place the patient? Because so far as we are working in resource-poor settings, patients just receive the care, they just receive the digitization, but they are not part of those who participate in this. And if they participate, and as they will maybe be granted more and more access to internet and to healthcare information, what would be the better patient involvement? To really try to find that balance, I think it is worth a reflection. Yes, and I think I would stop there maybe to give the chance for the other panelists to share.
Barbara.
Yeah, sure. Just quick 1 minute for me, very much noting time as well. But firstly, yeah, I sort of hope AI needs lots of data. So to me, the next 1 to 3 years, I hope is getting the basics right. Train the health workers, phones get cheaper, internet gets more available. Let's talk about basic tests. I was on a panel the other day talking about precision genomics for global health. And I'm just like, let's do basic blood pressure monitors first, please, people, before we start talking about anything too fancy, you know? So yeah, I just hope over the next 1 to 3 years, we get the foundations right, we get the foundational data. That is the key to success, interoperability, data standards at the core. Just wanted to also echo, for what it's worth, Krishna's point earlier, is I do see it being massively unequal by country. We can do way more with health workers in the Philippines than we can in Indonesia. In Indonesia, the health workers can't even do basic blood sugar screening. So I think we're also going to see quite uneven and patchy development of health workers in the different markets that we work in. But still, I just hope it's all working towards those strong foundations before we start talking about the bells and whistles, so to speak. And I'll pause there.
Yeah, I'll just come in and say that what we really want to focus on is data-driven action next 1 to 3 years, right? I mean, analyze data, going back to the health workers so they can use the data to prioritize their services is the focus for us. And with respect to AI, so we've got a collaboration with Harvard and Google on using AI, integrating AI with every aspect of our working. And since we work so much on high-risk factor management in pregnancy and childhood, we really want to integrate AI with every level of the system so that eventually, you know, we'll be able to kind of, with improvement in data quality, we'll be able to get into prediction of risk factors. Just.
I'll try and be brief. Big things, posting, and especially for ministries of health, getting their heads and arms around self-hosting and cloud-based server security being probably as good as, if not better than, on-site servers, not going down the road of very heavy, very expensive, and ultimately sort of redundant hardware, and those kinds of investments is a big one. We're already using machine learning, distinct than AI, in data quality, and I've shared in the chat sort of a link to the data observation toolkit, which is something that is open source, and love to follow up with those of you who are concerned about data quality and what to then do about it. I think another really, really big one is climate, and and the environment, and we're currently sort of partnering to pilot a community-based resilience toolkit with an organization called Scope Impact with funding from the Rockefeller Foundation. And we'd be really excited to share with you what's coming off that, but looking at sort of increasing self-reliance and preparation and mitigation of some of the impacts that we're already seeing and will continue to see are very important. Thank you.
Thank you very much. I think we are right at time. I don't know if anybody in the audience has a quick specific question. We do have one question from the audience about panelists partnering with startups who work with community health workers in Nigeria, a digital healthcare platform leveraging community health workers to provide on-demand primary health care for individuals and businesses. You partner referrals in Nigeria. I can certainly take that offline with Jenny and find her partners there. Any other questions from the audience? Okay, I think we covered quite a bit of. We got one message here. Okay, that was from Aparna. Well, outstanding. I mean, so it's what I've heard is that we are making steady progress, but there are challenges ahead that I think are recognized but that can be overcome. But we do need to sort of, as I sort of build the foundation before we add the bells and whistles. Some to be variable from state to state. Certainly, communities need to be involved in developing the proper training and staffing. The government needs to be involved in as far as infrastructure and data policy, in deploying everything intelligently so that the impact is realized. Yeah. So was there anything I missed or any other parting thoughts before we say goodbye? Well, thank you very much all for joining us today. I thought it was a great session, and hope everyone has a great rest of your day.
Thanks so much. Goodbye.
Take care, everyone.
Thank you so much. Take care.